hand up, but I'll, in the meantime, I will bring up my PowerPoint. Sorry, I know it's hard to just be inundated with PowerPoints. Can you see that? Can everybody see that? Okay, great. Okay, so my name is Jennifer. I'll introduce myself in a second here with a slide, but I am an early career researcher, and I just finished my PhD mid last year, and it was on promoting nurses' performance of basic life support in non-intensive care hospital wards. So this is my presentation. So a little bit about me is I graduated in 1996 from Indiana University in the US, and I worked for 10 years in the States. Was lucky enough to get in on the ground floor in a cardiothoracic ICU, and I couldn't believe it when they hired me. I interviewed just in case as a new nurse, but they said they wanted to grab me early before I learned any bad habits so I could learn everything with them. So that was great. And that took me then into a role when I moved to New Zealand into the cardiology and respiratory clinical nurse educator. And that morphed into a resuscitation officer role, which is what really piqued my interest in doing resuscitation science. And now I've just started as a university lecturer in the School of Health Discipline of Nursing at UniSC. So, yeah, so I'm going to talk about resuscitation. I want to give you just a little bit of background, and I'm sorry, I don't mean to sound patronizing or anything, but I just want you to understand I'm talking about such a little bit of resuscitation in such a specific cohort and type of resuscitation. So when we say CPR, we really mean certain skills like chest compressions, airway support and management, and defibrillation. Okay, now I know it's a bit small, but what you can see here is the chain of survival. And you'll see the term early a lot. So of course we want to prevent it as much as possible, particularly in a hospital where, you know, we're visualizing our patients, and hopefully we can you know, get it while it's still just an emergency as opposed to an arrest. But if it isn't, early initiation of chest compressions, early defibrillation, really, really important. And those CPR, airway management, and defibrillation steps are really what's considered BLS, basic life support. Now, as an ICU nurse, I was always what's called advanced life support trained. So I didn't really have a lot of knowledge about basic life support education surrounding it until I became a resuscitation officer. And some little things just kept popping up, complaints from nurses, some insecurities, and some issues. So that's when I got started. Just a little background on the science of resuscitation and management of, or policy and procedures. We have ILCOR, which is the International Liaison Committee in Resuscitation, that was established in 1992 to help facilitate consistent CPR and collate CPR science, and then share that out, have it coming in and out from the international different resuscitation committees. So Australia, you know, Canada, America, European Resuscitation Council, all of that. Okay, so ILCOR is what helps guide. We've got a lot of people here in Australia who contribute to ILCOR, participate, and then in ILCOR. And there is an expectation that hospital-based ward nurses, okay, not critical care nurses, but ward-based nurses will be competent, that's not a favorite word of mine, in performing basic life support. Okay. And remembering that basic life support, if basic life support isn't initiated early and maintained, then there is no need for advanced life support because it won't get that far. Okay, so the study context and statement of the problem. So again, there is no question. Rapid initiation and effective basic life support saves lives. That's not ever a question. However, unfortunately, in global research, there are studies showing that there are delays in this initiation of CPR, inconsistencies or inaccuracies with following guidelines and algorithms. We do know that it's a stressful event for any healthcare worker, right? Anytime you have an emergency situation, anytime you have different teams, people working with each other who hadn't necessarily worked before, we do know that it's a stressful situation. But unfortunately, there's been very little research, particularly qualitative research, being done on hospital-based ward nurses. So if you look at a lot of the research, it's either on skills, technical skills, it's on advanced cardiac life support, it's on out-of-hospital cardiac arrests, and CPR, it's on medics, so medical teams, intensive care teams. So this is sort of, I saw a big gap in the literature here, and that was one of my reasons I wanted to do this. So I was asking myself, because at this point I was a resuscitation officer, and I'm like, and teaching a lot of this. So how can we as educators meet basic life support requirements if we don't fully understand their experience of performing basic life support? So that's what I decided. All right. Oh, and hospitals, gone are the days that patients in hospital wards are stable. I remember when I first started, patients would be in the wards overnight because they were waiting for a ride to come pick them up the next morning. And now that's just really unheard of. I mean, beds aren't even cold before the next patient gets in. And patients who used to be some intensive care patients or high dependency unit patients are now in the wards, okay, just because of bed management issues. And we know people are living longer, people have more comorbidities, they have, polypharmacy. So we're seeing an increase in complexity of ward patients, thus leading to more arrests or possibility of more arrests in hospitals. All right. Please stop me at any time if you have any questions. Okay, so I asked, what needs to be done to improve the confidence and performance of nurses in the provision of basic life support in non-intensive care wards? And the reason I included confidence was because a lot of research shows that for somebody to have a good sense of self-efficacy and confidence in something, they will obviously perform better. Okay, so I thought, okay, well, let's go for both. Let's go for improving confidence and improving abilities and performance. So the aim of the overarching aim of the PhD was to improve the confidence and performance of ward nurses in the provision of BLS and non-intensive care wards. Okay. So the first thing I had to do was a literature review, and this was my first time ever. So it was interesting because it was hard, very difficult for me. I wanted to determine factors that may affect ward nurses' ability to perform CPR in the workplace. So what I did was, now I want to tell you my dates. I searched from January 2020 through to 2022, June. The reason I only went back to 2020 is because a lot of things changed around that time, particularly with defibrillators. So historically in hospitals and defibrillators were kept in an intensive care or emergency department. They were manual, they were big. Users needed to know to be able to recognize a lethal rhythm when it was indicated or not. And that was changed and rolled over around 2000 globally for wards to now have little AEDs or automatic external defibrillators. And that's when defibrillation became part of basic life support as opposed to advanced life support. Okay, so I didn't want to go back much earlier than that. So these were my keywords and my Boolean operators. Here's my Prisma. So I ended up with 9 studies. So for 22 years, I found 9 studies that were appropriate. So 9 articles, only 3 were qualitative. But I did get 8 different countries, so that was good, including Australia. Came up with about 5 different themes. And what you can see here, and I'm going to use these terms a bit, is both technical skills, and human factors. So human factors, interactions, communication, teamwork, critical thinking, things like that. So again, really 3 qualitative studies over 22 years asking ward nurses what they felt about their experiences of performing CPR. So what did we conclude? We conclude that there were multiple concerns, both human skills and technical factors. It did also highlight the lack of research, particularly qualitative research on ward nurses' experiences of performing CPR. These experiences need to be more fully understood. And why was this so important? Because as an educator, particularly when you're looking at adult learning theories, you know, if you go way back to Knowles, adults want to know why they're learning what they're learning. They want to be a part of the learning process. They need to be able to make sense of what they're learning. So, you know, how are we going to teach people things if they don't, if we don't understand why they need them? So anyways, we wanted to improve, we thought we could improve outcomes for patients having a cardiac arrest in hospital if we could improve the education. So after the literature review, I had to choose a methodology. So I chose an exploratory sequential mixed methods method. I was really lucky. When I was just starting this, there was a qualitative research conference here in Brisbane, and this John Cresswell was there, and I got his book, and it had all of this in it, and it really helped guide what I was doing. So there were 4 stages here. So qualitative study, then those findings would be integrated and inform my quantitative tool and intervention. Then I would do the quantitative study and then interpret it and weave it all together in the final stages. So the first thing I did was a qualitative study to gain insight into ward nurses' experiences of performing BLS, but I also wanted to know, what are your feelings about your existing BLS education? So again, what were thoughts and experiences of performing CPR, and how could we as educators improve your CPR training? So this qualitative study also was published, and this was published in the Nurse Education and Practice. That took 5 submissions, but I finally did it. Woohoo! That's another thing. So my qualitative study, this was ward-based nurses at 3 Metro North hospitals who had not been advanced life support trained. Okay, so these nurses had been involved in at least one real life CPR situation within the last 2 years. Consent was verbally confirmed at the time of interview, and I ended up with 15 interviews. So these were semi-structured interviews within the workplace. Some I had to Zoom. Unfortunately, this was right when COVID was in its prime, and so I got kicked out of some of the hospitals and ended up doing a couple of face-to-face interviews. It was touch and go for a while there whether I could even complete this, so I was quite lucky that I got to. I used the NVivo 12 for my data management, and I used Braun and Clark 6-stage inductive thematic analysis to transcribe the interviews. So please, I know this is a lot. My supervisors hate this slide, but I did not end up putting it. I did change this a bit. However, what I want you to see is we came up with 4 themes: barriers to performing basic life support, facilitators, basic life support education issues, and the psychological effects of performing basic life support. So what you'll see is we've got 9 barriers, 3 facilitators, some information on the negatives and positive thoughts, and what can be improved on and included in CPR education. And then all of this emotional stuff. It was really interesting. And I actually felt quite bad because it just seemed like some nurses were still thinking about events a year later. and there weren't any avenues for them to have discussed it afterwards. So like no debriefing, things like that. But this is where all those human factors are coming in. It was really interesting to talk to people who were both, very novice nurses and experienced nurses who've been around the block. So what you can see here in these barriers are there's a mixture of those human factors and technical skill deficits and knowledge deficits. So this was quite eye-opening. And listening to these nurses, because you go in there with your own sort of feelings and thoughts. It really was important to listen to the nurses to get this information, because some things came out of it that I didn't expect. But what I did seem to find with all 15 people was that their BLS education was not meeting their needs in one way or another, whether it was the content or the frequency, okay, all sorts of things. Okay. And then obviously this is very complex. So I wanted to develop an intervention, which was sort of the whole point. Can a curriculum be developed to more comprehensively prepare ward nurses for in-hospital cardiac events? All right, so again, I'm sorry about the slide being so full. I used, so to make this education curriculum, and why I didn't before my study, a qualitative study, is I wanted to take the findings from that qualitative stage to integrate and develop the curriculum. I took some educational framework, so the evidence-based practice framework, constructivism, so building on people's prior knowledge. It is an expectation that they do this once a year and sometimes more frequently. And Knoll's principles of adult learning. And let me just say something here that I found really interesting is, remember I said that I had been a clinical educator. I was chosen to do that because of my experience in the clinical space. I had had absolutely no formal education on education techniques or learning or teaching. And I think that was a big thing that I found here as well, is that that's a big problem. All right, and of course I had to integrate the guidelines. So I used the European Resuscitation Council's 4 principles of education for resuscitation training. So I used all of that and developed a curriculum. Now, again, it looks quite big, but I won't go through it all. But what I want to say is, if you're thinking, oh, this looks like it should be a normal BLS class, basic life support class. This was an hour long, which at 2 out of 3 of the hospitals that I went to, their courses were 15 minutes. There was pre-learning, then they came down for a tick and flick, and they were just watched on technical skills. So initiating CPR, the technical skill of chest compression, so depth, rate, defibrillation, and airway management. Okay. So what I tried to do was spend the whole first 10 minutes of a group, and we tried to keep these to 6 people or below per group. Was lots of human factors, talk about it. You can be nervous. You all are going to be nervous. That's okay. I had so much feedback from people saying, oh, I thought I was the only one that was scared and nervous. Lots of discussion, and that continued throughout. I wanted people to continue to, and I was the one facilitator for all the sessions. I wanted people to talk to me. I wanted them to be vocal about their insecurities and their emotions. And if it was a smaller group, I think it would have been a safer place. Lots of repetition, lots of deliberate practice. And another human factor was the communication and delegation, a lot of professional hierarchy issues, a lot of cultural issues from people who don't come from a Western society. So people had to use their voice and delegate with the defibrillator loud enough and accurately enough until I was quite happy, and until they had a big smile on their face and weren't shaking anymore. So we had a lot of good. This 10-minute debriefing didn't always happen because it lasted a bit longer, but we definitely talked about stuff throughout. And if there wasn't a class following us, we spent some more time. Now I want you to see here, there is no competency. There's no check off. We did not say, okay, you're competent, because really, if you look at the efficacy of competencies, that's more for the hospital to just sign off. Yep, we had people come through, but it's not really saying whether somebody is competent or not. And a yearly competency for this is probably not enough. So we wanted more more effective training as opposed to efficient training. So this was the intervention in my quantitative study, and this was to address the recognized barriers that nurses reported, to increase the confidence and ability. And the question was, will this innovative, I said innovative, I didn't know what to use, I know targeted BLS education session improve ward nurses' competence and perceived abilities of performing CPR? And again, remember, this is basic life support. So this is written up. I'm just submitting this again. I had a hard time with this one, the qualitative writing up. I ended up getting a statistician to help me with what to report, how to report. It's really Greek to me. I'm not sure why it's so difficult, I suppose, because I was learning, but yeah, it was a tough one for me. So that's been rejected 3 times. So I'm going to try again here. It's hopefully ready to go now that I talked to a statistician and got a lot of stuff reorganized. So these were 1-hour innovative BLS sessions conducted at 2 participating Australian hospitals. Now I was doing it at 3. But one of them, nobody showed up to my classes because that was the one hospital out of the 3 that the director of education said that this course could not count as their yearly competency. Even though theirs was 15 minutes and a quick tech off, but I won't get into that. So I had nobody show up. So I was sitting there for 5 days, over 2 weeks, with nobody coming, while I was watching them do a 15-minute tick and flick in another room. But that's all right. I ended up doing 19 days, over a month and a half, November, December 2022. So these were nurses who required BLS training, again, not ALS. I kept it to about 6 people per session. One had 7. But it went all right. This was a quasi-experimental single-arm post-intervention evaluation, which, by the way, I didn't come up with that. Somebody helped me with that. So I used Likert scale questionnaires at the end. So I had 159 nurses, and I used the SPSS for my data. Now, I asked... this is the first of 4. I asked, the first of 8. I asked questions not only pertaining to the course, to how people felt, but content of the course. So it's just some overarching, I feel that the content of the session was comprehensive enough to prepare me. Again, confidence. I felt my confidence in initiating. I felt my confidence in performing, because remember, one of the issues is actually starting CPR. And that's one of the reasons Europe, Australia has taken checking a pulse out of those initial stages. If someone is unresponsive and not breathing, you start CPR, where the American Heart Association still has checking a pulse. But people were found to spend up to 2 minutes looking for somebody's pulse. Oh, I can't feel. Hey, can you come and check? Hey, can you come and check? Hey, can you come and check? Right? So rapid initiation of CPR is just as important as performing effective CPR. So I asked about that. Then I asked about human factors, because this would have been the first time many people would have had this in their session. And you can see some nice big numbers here. And of course, this was, in a lot of cases, within 15, 20 minutes after the session. So I will do a follow-up, and I'll talk about that in a minute. Again, delegating. So these human factors, talking to people they don't know, talking to people they may not get along with, talking to people in other disciplines, right? So we discuss that a lot in our course. So yeah, so being able to perform, being able to initiate, being able to talk, it all got some really good feedback. I did leave one area for some subjective responses. 64 people, so that was about 48%, I think, of the people wrote a little something. Lots of repetitive, so thorough, good to talk about their experiences. Yeah, small groups. So good positive results all around. So integrating that, again, I know this is a lot. If we go back up to the qualitative stage here, we found there was lots of anxiety, a lot of knowledge deficits, a lot of human factors, role confusion, lots of defibrillation concerns. And we decided that BLS education was not meeting the learners' needs. So we took their learners' needs from asking them and relevant educational frameworks, and we developed this curriculum, and we feel that addressing these learners' needs during BLS education improves their competence and confidence when performing. So that was integrating those findings, and that was using from Fetter's, it's called a weaving approach. And what was nice about the mixed methodology, and this is why I wanted to do it, was that each study helped to validate the other one, gives a little bit more confidence and rigor. So again, that's a bold statement to make, that current BLS education is not meeting the learner's needs. But we found that along with the short sessions, the competency-based, that it really isn't. And again, very little inclusion of human factors. So some recommendations, and I've sort of pared these down, to engage hospital-based nurse educators to undertake their own learning and evidence-based adult learning theories, because how are they teaching people? Are we still doing it sort of, yeah, you're the empty vessel, I'm your teacher, you're going to learn from me? Competency-based really isn't effective, so we need to get clinical educators up to date on this, and I'm willing to go do sessions with them. Lots of inclusions of human factors. We need to talk about it, talk about it, talk about it. Nobody's talking about it. Try to reduce this anxiety, this overarching anxiety that surrounds all, but people are nervous when they come to training. So think of how nervous they'd be in real life. And you think about the frequency of it occurring. It can be years between events. More time needs to be allocated on hands-on, deliberate, repetitive practice. It just has to be defibrillator. Use it again, again, and again, and again. Go through that initial bit of the algorithm to encourage that early rapid initiation of CPR, okay, instead of overthinking it. Encourage the inclusion of debriefing. That is really, really important, even if it's just an informal, look, guys, let's have a 5-minute chat. And it really should include observers who weren't involved, because a lot of times they have a clearer picture of what happened than what the people did. People can be overcritical of themselves, particularly when they're really stressed. More frequent education sessions, definitely. And again, including human factors. Now, one of the things that was really interesting that people said in the interviews, and a couple of people had said it in the course, is that, oh yeah, we come down here to the education centers and the skills labs and everything's already set up. So, there is a nervous, there is a part that, oh, I've got to open up a brand new resuscitator bag, or, oh, where is the crash Charlie, that kind of thing. And it was really interesting. And this aligned with a couple of studies, particularly one in Brazil, where most people have never looked in the arrest trolley. So, because what it is it's delegated, again, for efficiency, not for efficacy, to one person. Like, I don't mean one person like Bob, but like a nurse on night shift, the person over here, you're going to check it. So a lot of people never get the opportunity. So they've never looked in it. They've never used it. What I tried to do, I had applied for a grant from Zoll for this first one to get a lot of bamboo bags, defibrillator pads, things that people will have to open for a first time. I mean, really, the defibrillator bag should be open, but that was one of the things this man said, that when he went in any other time, he could put the resuscitator bag together. or it is together, but because he was so nervous and someone was arresting him, someone was yelling at him to get the bag, it was still it hadn't been used or put together. So his hands were shaking. He was so nervous. He didn't know what to do, and someone had to help him. And he thought about that for days afterwards. So that's unfortunate. So I wanted people to be able to use things. And so I went around to all the hospitals and tried to find expired stuff. So we got some of that in. But again, they need to be practicing this in their environment where they're actually going to be doing this. And I cannot stress enough, and this is in all this stuff about interdisciplinary scenarios, again, we've got these professional hierarchies. It was hilarious when I was in New Zealand, because at the hospital I was at, it took me forever to try to get the orthopedic docs to come and do just a simple basic life support course. Many of them hadn't been for like 20 years. But what we were seeing particularly junior nurses hesitate or look at them or whatever surgeon they were, to initiate or decide that CPR should be started when these people were saying, I don't know, you do it. And they're saying, I don't know, you do it. So we have a real problem there. So lots of interdisciplinary stuff needs to be done. There are some barriers, lack of organizational support. I had nurses telling me constantly that it was their third, fourth, fifth time trying to get off the ward to come to training, whereas a lot of the medics have protected education hours, nurses do not. And then I was surprised by some of the comments from nurses, not only from who I talked to, but in the research, this lack of awareness of accountability. They felt a responsibility, but certainly not an accountability. And that was really interesting to me. And it was a bit disappointing, and something I wouldn't mind looking at in the future, about how nurses feel this is they're accountable for this. I think when they think of themselves as one part of a healthcare team. But remember, nurses spend the most hours with these patients. They're there a lot of times they're there, right there, and they see that. And when the time is of the essence, it's really important that they are knowledgeable and accountable. So research recommendations, definitely more qualitative studies to ask nurses how they feel, how they felt, how they went. And, obviously nurses who have done this multiple times have real different experiences each time, of course. Definitely need to look at consistency of BLS education sessions. What are we teaching? How long are we teaching? How often are we teaching? Who is teaching? Right? So, and then longitudinal studies, and this is what I'll talk about here in a sec. So there were definitely some limitations to this. I was disrupted by COVID twice. It made a little comeback while I was doing the education sessions, but we went an extra week quite close to Christmas that I didn't expect people would want to attend, but they were keen, so we ended up getting enough numbers. There were 3 sessions that only had, they had 1 or 2 attendees. I brought in another educator for the one that had 1, so it was 3 of us. And then for the 2, it was me as well. And so we were able to do the scenarios because we had someone on the airway defibrillator and chest compressions. But I made sure that they were the ones who were doing the defibrillator, delegating, running the scenarios. And that was a really good one because we had a lot of time to talk and a lot of extra time for practice. Again, this was a Queensland study. This was at the Prince Charles. This was at Redcliffe and Caboolture hospitals. So that could be a limitation, not generalizable. And I was the one facilitator for all the sessions. So again, I could have had some part, in affecting the outcomes as well. So those were some of the limitations. And lastly, well, not lastly, I'm getting there, I promise. I was quite lucky, or I was quite happy, because at Caboolture, now see, this is interesting because the educators at this hospital were completely different than at another one. They recognized that what they were doing for their BLS education was not preparing nurses. They were given a certain time slot. They had to do all of these nurses during this time and this time. And it was just like a little conveyor belt. Let's get them through, get them through, get them through, so the hospital can sign off that this has been done. As opposed to efficiently or effectively teaching or facilitating these sessions with these people. So they were really keen to take this on board, and the director of nursing agreed. So they now run these 1-hour sessions for their at their hospital-based orientations or their yearly mandatory, and not just with nurses, for anyone who needs basic life support. So new medics, med students, physios, pharmacists, midwives, I don't know, anybody, most people have asked, I suppose. So I went and did some train the trainer days with the clinical educators who run these. And like I said, those educators were invested in this, which is great. So what I'm going to do now is I just received my first grant from Zoll, finally, to do that follow-up study. So I'm going back. I'm in the process of doing my ethics. I've submitted my ethics approval, just waiting for Queensland Health to do a multidisciplinary healthcare professionals' perceptions on the effectiveness of these. So I don't want to just talk to the nurses. I want to talk to everybody. So I'd like to interview about 10 people from each discipline and see how they feel about it. This is brought me into as an early career researcher. So I was able to, quite early on in this, I attended a Queensland Cardio, I became a member and attended the session up at Sunshine Coast. So I presented this not this, but the first part in poster form. That's how I got involved here. And now I'm on the early career researchers group. And I was so lucky, I got accepted into this was in August, September last year with the young, I love that it says young, European Resuscitation Council Resuscitation Science Masterclass. So this is a year-long program I'm in. There are 4 workshops, webinars, journal clubs a month that I attend, which are on Europe's time. So they're about 3 and 4 in the morning here, but that's cool. These are the people, half of them that I cited in my thesis. So these are the heads of ILCOR, the heads of all of this resuscitation stuff, who are giving us these amazing workshops each month. And then I'm going to Austria in July for the in-person capstone event. So that's been a really good opportunity for me, and I'm learning a ton in that. And that's it. Whew, sorry. I talked right. Thank you.
Excellent job.
Thank you.
I know before we started, you were worried about your pace. You were worried about talking too fast. I thought your pace was spot on there.
Oh, was it?
Yeah.
Oh, yep. Good. I got a bit excited a few times.
Look. Yeah, no, I thought it was great. I thought it was great. And look, that was for me, that was an absolutely fascinating presentation. I learned, right, that the stage one study, particularly with the barriers, mate, that could have been a podcast. I could have listened to that, for hours. It was just fascinating. And for somebody like me, coming from a completely different background, this is stuff that I'd never considered. I'm like, holy shit. All right, I can see Andrew's got his hand up.
Yeah.
Thanks, Jennifer. Yeah, it was fantastic. No, I don't know what you were talking about with too quick. It was easy, and I'm very slow-headed, so if
I had my sign with me. My slow down sign.
It worked a treat. Yeah, really interesting, and sort of I definitely hear and agree with what Jason said, that initial phase of that qualitative exploring was really interesting. But I think as a whole beast, it was a really practical and pragmatic approach to use mixed methods to sort of utilize qualitative and quantitative to explore, then sort of confirm, explore a bit more. There's so I used mixed methods exploratory approach, so use a sequential approach. So I understood a little bit more. But yeah, my only question was, and you alluded to this throughout your narrative, and I was just interested to see, and maybe I missed it. Did you capture the years of experience that each individual nurse had, and/or how many experiences they had in BLS events?
I did have there, yes. So
Was there a correlation between their views and or confidence and
No,
or?
yes. One of the only correlations I found out of anything was previous CPR, real life CPR experience with confidence. So what I didn't include in that last bit were in that Likert scale, I had asked 4 questions about how people previously felt, how they felt previous to the day. But in that qualitative, because I did talk to some very experienced nurses, even if they were experienced, but they had no CPR real life experience, they were very anxious and didn't have a lot of positive things to say. Yeah, they were very scared. Yeah.
Fantastic. Thank you
Yeah.
for your talk.
Oh,
Yeah,
thank
great.
you. Thank you very much. Yeah, I like the mixed methods too, because it really, each stage validated each other, didn't it? And it gives that sort of rigor or whatever. These are all, words I'm not sure I'm using right, but it really helps you see that, really gives you depth, doesn't it?
Yeah,
More
I think
depth, I think, if you did one on its own.
it is, and I think it puts and there's a quote that's used in a citation I use for my mixed methods study of putting the power of stories to the something of numbers, something like that.
Okay,
And
yeah.
I think I used that in mine because I quite like that little sentence because it gives a contextual understanding of the numbers, right? The numbers can tell us a very explicit black and white part of the story, but those words, those stories that surround those sort of gives us a greater contextual understanding of what those numbers mean. So,
that's right.
No, once again, fantastic.
That's right.
Great.
Thank you very much. Thank you. Thank you. Thanks, Andrew.
Joseph, you seem to be next in the queue.
Thank you. Well done. Thanks,
Thank you.
I'm just going to make a few comments, if I may. I got a phone call from the school. Child is not dying, and no one's providing basic life support. So I'll avoid asking a question in case I miss the answer in the talk. I just wanted to say, first of all, congratulations. Well done. Thank you for your honesty in the way that you shared your story. So getting rejected umpteen times is sadly part of the game, and too few people recognize that. So certainly within an early and mid-career crowd, it's extremely valuable and should be completely transparent that that's normal part of the process. So good on you for that.
Thank you.
Secondly, I mean, the other thing I guess I would ask is, you've looked at large centres, but how do you think the experience might vary between, say, rural or metro or, larger centres versus smaller centres?
Definitely a limitation. And, it was interesting because I think one of the things when you start your PhD is you almost are forced to put on blinders because everything, I should do this, I should do this, I should do it here, I should do this. But you just can't. So those are all things I'm very happy to look at. For this European Resuscitation Council thing, I have to develop a proposal for some future research. And I was thinking about doing some, because I have some friends who are rural nurses and teach up early and nurse out there. And I think that'd be really interesting because nurses and allied health and physicians out there tend to be sort of have their hands in everything and have to be the go-to people. So it'd be really interesting. And that's definitely something I can look at in the future. Yeah.
Cool. And then finally, never apologize for your lack of understanding of all aspects of methodology. Statisticians are weird. I say that as a quasi-statistician, but they're there for a reason. And again, you're not expected to know everything. That's why we build teams. You brought your own expertise, and then you relied on the expertise of others to lift you all forward. So yeah, good on you. Great to hear.
Thank you so much. Thank you, Joseph. Thank you.
Katina, you've got your hand up. You seem to be next in line.
Look, thank you very much. Actually, I'm working from home today. I apologise. Someone's leaf blowing next door. I'll have to mute myself if they continue or go out and take matters into my own hands. But look, thank you so very much. I'm a coronary care nurse by trade and sort of a bit of cath lab still. And so actually that resonates with me, often having, ward nurses from other areas apart from coronary care, bringing ECGs over to interpret because they're unsure, etc. So, and people like when the code occurs, of course, having people running in, sort of racing around like lunatics with their hands in the air and no one sort of taking action. So that
That's right.
really does resonate. But my thoughts are, especially perhaps for future research, perhaps, you might consider looking at something interprofessional sort of educational framework, perhaps to look at team effectiveness in undertaking BLS rather than at an individual level. Just a
Yep.
thought.
Yeah, sorry. Of course, I'm working from home today too, and my dog is barking. He's been good this whole time. I'm so sorry. I agree. And and that's why I'm looking at this multidisciplinary thing. What I wanted to do initially was do these CPR classes, these BLS classes with anyone who needed them. But it was just too hard for me to hone in on that or to expand on that in my PhD. So that's definitely plans because, from someone who does advanced life support, that's how you do your training. You have anesthetist there and you have EMTs there and you have people from all over who work, from all over. And I think that if we, interdisciplinary, everything is important now. Education, university wise, teaching people things. So you're absolutely right. And there's so much research needed on this, particularly teamwork and these human factors. And it's actually quite funny because when I was, I hope this doesn't stop in 5 minutes. Will this meeting automatically stop?
It shouldn't.
Okay.
Not Zoom, so it should be okay.
Okay. If it does, I'm so sorry. It was funny because, this European thing I'm taking, the European Resuscitation Council, we were talking, somebody did a talk on qualitative research and everybody else freaked out, like, because they're all sort of in the labs and quantitative. And I was like, yeah, I know this. I'm all right with this. So it really shows how little people really think about the human factors as opposed to ventilation and skills like that. So, yeah, it absolutely. Yeah. So I definitely think we need to talk to people because, there's no reason this should fall on other people and maybe they're stressed as well. Can you imagine a brand new doctor, it's their first weekend and everyone stops and looks at them at what to do. So no, it's neither appropriate for the people who aren't doing anything, but also for that person to have everything rest on their shoulders. So yeah, you're right. So I would be happy to work with anybody or collaborate with anybody who wants to do anything like this. Absolutely.
Yeah, no, that's great.
Yeah.
That's excellent. I've
Thank
been
you
working
so
with
much.
paramedicine, dentistry, nutrition dietetics,
yeah.
and our School of Nursing to implement that. As interprofessional, I was the interprofessional learning lead for a few years, but yeah, we're developing a hybrid model, so that will pilot test that
That's
this year.
great.
So,
I'd love to see that. And I was talking to Chris Askew the other day, who these students of theirs all work in these cardiac rehab patients. These are high risk patients, so I'd love to do a study with them and their students and see, what sort of resuscitation knowledge or qualifications people have.
Sure.
Yeah.
I might reach
Yeah.
out to you. I'm past president of ACRA, so I might get you perhaps to join us and present to us one sometime
please,
soon.
that
I'll
would be
send you an email.
great.
Yeah, great.
That would
Lovely.
be great. Thank you so much.
You're welcome.
And thank you so much. And Carrie is a nurse practitioner in New South Wales. Oh, I'll come visit your hospital. I'll definitely. And don't tell me you'll listen to me for hours because you'll have to. And yeah, Andrew, definitely, especially remote. Yes. Yeah, definitely good to it is good to get everything and in Australia we have our own dynamics, don't we, with rural kind of stuff and rural and remote. And I'm not saying other countries don't, but and with indigenous peoples and the multiculturals, we have, and I'm sorry to say it, and I suppose I don't mean to get so rough with them, but we have people coming in from, nursing who are in their third year and can barely communicate verbally in class with me because that's not their culture to be, confident and loud and talking to somebody who's older than them. So, the expectation is that they have to do that in hospitals. So you can see how that can be a real problem. And nursing, nursing in Australia, it's like the 20th year or something that it's the public's most trusted profession. We can't let them down, right? We need to maintain that. I can see Jason and Joseph about Townsville. Oh, Joseph, you're in Townsville. Nice. Yeah, great.
Look, I think if there's no more questions, this has actually run pretty much perfect in time, despite my gas bagging at the beginning. We're pretty much bang on 1 o'clock. And look, I really, again, thanks everyone for taking time out of your day today. Jen, thanks so much for volunteering to be our inaugural presenter. And look, I think it was such a good presentation to open up with. It was so informative and so interesting. It was brilliant. And I hope that even though there was a small turnout, I hope that the turnout helps progress this work.
Thank you.
This work progresses, other people's. Brilliant. Anyway, I'm going to run because I've got to have lunch with my next meeting. But thank you, everybody. This was awesome. Thank you so much.
Thank you. Thanks everybody.
Guys.
Feel free to contact me. Thank you.